My name is Anthony Pham. I'm a medical oncologist at Compass Oncology, and I was asked to give a talk about what I would want my patients to know when they're walking through the door. And I thought about it long and hard, and I don't have prostate cancer, but I asked my patients, specifically two patients, what did they want to know before they came through the door? And so I thought it'd be interesting to give you an idea, and actually this is their actual feedback about what they wish they would have known walking through the door. Now, first guy I'm going to tell you about, I'm going to call him Mike. That's not his real name. This is not his real picture, although he says that he's actually much better looking than this, and frankly, I know better than to argue with him. He's 55 years old. He has something called a PSA that's 15.3 and something called a Gleason that's 4 + 3 = 7. And his father had prostate cancer at the age of 57. That's why he got all this testing done. And his scans were negative, meaning that the prostate cancer didn't spread anywhere else. And the first thing he said to me was, "What does this all mean? Like, why are you throwing all these abbreviations at me?" So I thought it'd be nice to give you an idea or background of what this all means really. So the first thing I want to talk to you about is something called a prostate-specific antigen, or what we abbreviate as PSA very commonly. Now, you should also know that it's not called prostate cancer-specific antigen. The name of this is basically a fancy way for us to say that it is a protein that your prostate normally produces, and when it's high, it can be a manifestation of many different things. Infections can make this number high. Just doing a prostate exam can make this number high. And so even though it's high, it's an indicator of what is going on in the prostate, it's not specific for cancer. However, we can use this to determine, hey, is your risk of cancer high enough in the test to warrant a biopsy? Now, a urologist will then do something called a prostate biopsy, and we ask pathologists or microscope doctors to take a look at this information. And we ask the microscope doctor to tell us, how aggressive does this thing look? And we score it on a scale of 1 to 5, meaning 1 looks like normal, 5 looks very abnormal. Typically, when you look at a prostate biopsy, normal cells basically look like they are wells, and they form small circles. However, if it starts turning more into prostate cancer, those wells or those circles go away. And so what we ask a pathologist or a microscope doctor to do is to tell us, hey, how aggressive does this thing look like under a microscope? And give me a score from 1 to 5. How bad does it look? And they give us one score that tells us, hey, how common is or how aggressive does this look? And then we ask them to give us a second number. So then what we do is we ask them to combine those numbers, and on the bottom here you see Gleason score blank plus blank equals blank. And all you do is you just add up those numbers and you can get a final Gleason score. Now the image on the left is what normal prostate should look like. You see circles, they make wells, they produce proteins and secretions to help normal functioning of the body. Whereas if you look on the right, this looks like prostate cancer because you've lost all those appearances. So when we get these numbers and we get this information, we can then use these numbers and this information to determine what is your risk that your prostate cancer is going to spread. And we can categorize them into 3 different categories here: low, intermediate, or high risk. When we start thinking about what we can do for low risk prostate cancer, generally we do recommend observation. However, if you have an intermediate or high risk prostate cancer, we can recommend many different options. One would be surgery with a urologist, or another option would be to have you see a radiation oncologist and a medical oncologist to treat you with both radiation and hormonal therapy. Now, you see asterisks in what we can do for patients, and the reason I do that is because all treatments are individualized. So you should talk to your doctor and you should get information about what treatment options are best for you. Now, I'm going to switch gears a little bit because I talked about Mike. He had prostate cancer that didn't spread anywhere else. And so we could use radiation and hormonal therapy and surgery to get rid of those tumors. I'm going to now introduce you to Ike. I met this gentleman about a year ago, and at that time he was 73. He had a PSA that's much higher than Mike. His PSA was 54.2. He has a Gleason score of 5 + 4 = 9. And unfortunately, his scan showed that the tumor had gone outside of the prostate, which is a very different situation than Mike. So in order to understand how we treat patients who have had metastatic disease, meaning the disease has gone outside of the prostate, we have to understand that prostate cancer basically eats testosterone. Testosterone helps the prostate cancer grow, and in general, if we find ways to block the testosterone, we can slow down the growth of the prostate cancer. And historically, what we've done is exactly that, meaning that we would give patients hormonal therapies or injections to decrease their testosterone level, and in doing that, we then subsequently decrease the growth of their prostate cancer. And unfortunately, in this situation, the prostate cancer will continue to grow again. So we then switch gears again, and we use different types of medications and hormones. And at the end, more than 5 years ago, what we would then do is give those patients chemotherapy when they needed it. But we saved chemotherapy towards the end. What we've subsequently found out, however, is that when we give these patients chemotherapy up front, when they're first diagnosed, before going through hormonal therapy, we can actually make them live a year longer, which sounds like it might not be much, but prior to all this, prior to 2015, we were not able to necessarily have many effective treatments that gave this type of result with just one drug. And so this is something called the CHARTED trial, and if you look at the top green line, it's basically using anti-testosterone medications plus chemotherapy, and we gave it for only a limited duration of time. And we compared this to patients who only got anti-testosterone therapy, and again, these patients lived on average a year longer. Now, fast forward to just earlier this year, we've also found out that if we gave people anti-testosterone therapy along with a new medication called abiraterone, these patients also tend to live longer, and in fact, half of them did not pass away over a span of 4 years. This is compared to just anti-testosterone therapy with placebo. So the reason I'm showing you these two studies, and this study is actually called the Latitude trial. The reason I'm telling you these two studies is because with just one medication and timing it correctly, we can now extend patients' lives out by more than a year with just one treatment. And in a year, what if we discover another treatment or sequence them in a totally different way? In that situation, we can keep pushing the boundaries and treat prostate cancer, even though it's metastatic, more like a chronic disease. So, what I would like to emphasize is that all prostate cancer treatment is generally very individualized. If knowledge is power, you should get all the knowledge that you can get. And so if you have any further questions about prostate cancer and the treatment of prostate cancer, please visit compassoncology.com for further details.